Good evening in Abu Dhabi. And thank you, Dr. Khan and the organizing committee for inviting me to participate in this 11th International Neonatology Conference. I will discuss collaborative controlled clinical trials and address the following question. What makes the difference between success and failure? I have no financial relationships to disclose. However, I will use the caffeine for apnea of prematurity, or CAP trial, as a case study in this talk. Therefore, I should mention, although Dr. Khan has already kindly done so, that I was the lead investigator of the CAP trial. Controlled clinical trials were introduced into medical science less than 100 years ago. Until then, physicians relied on experience, intuition, and uncontrolled experiments. The detrimental consequences of their actions remained mostly hidden, but we get a glimpse of poor practices by studying prominent victims of anecdotal medicine. For example, George Washington died in December 1799 at his estate in Mount Vernon soon after developing a throat infection. During his final hours, his treatments by several different doctors included bloodletting. 80 ounces of blood, or about 40% of his total blood volume, were removed within 8 hours. It has been disputed if this extraordinary and fairly acute blood loss was the actual cause of his death, but it could not have helped. The late David Sackett is widely known as the father of the evidence-based medicine movement. Here's what he had to say about bloodletting. 100 years after Washington's death, orthodox medical practitioners were still using bloodletting routinely. The reason why smart doctors continued to use dumb treatments was because they were prisoners of inductive reasoning as the proper route to truth. They were brilliant observers, but they were not experimenters, and observation cannot prove efficacy. The benefits of large randomized controlled trials are obvious. Without them, in perinatal neonatal medicine, we would be unable to confidently prescribe effective therapies such as antenatal steroids for threatened preterm birth, surfactant for preterm RDS, or therapeutic hypothermia for term infants with moderate or severe hypoxic ischemic encephalopathy. And equally, without those large collaborative trials, we would not be able to get rid of useless or unsafe therapies, such as routine resuscitation with 100% oxygen at birth, or routine endotracheal suctioning for meconium-stained amniotic fluid. Caffeine for apnea of prematurity has been called a neonatal success story. The authors who wrote this article credit the CAP trial for much of this success. So what made the CAP trial a success? On this slide, I have listed what I consider to be the most important ingredients for a successful collaborative trial. Firstly, we must ask a sound study question. Secondly, we need a strong network of collaborators. Thirdly, we need a supportive funding agency. Fourthly, we absolutely must work with an experienced and with a proactive DCC, which stands for Data Coordinating Center. And lastly, we also need a reasonable amount of luck. And this is because the best planned trial may encounter threats to its successful completion that turn out in some cases to be beyond the investigator's control. In the CAP trial, we managed to tick off each item on this wish list. So let's begin our case study with a closer look at the study question. And here it is in the PCOT format. Among infants with birth weights 500 to 1250 grams at risk of apnea of prematurity, does neonatal caffeine, when compared with placebo, increase the risk of death or disability at a corrected age of 18 months? Note that we set out to examine the safety of routine use of caffeine, and we therefore hypothesized that caffeine may actually increase or worsen developmental outcomes later in childhood. Thankfully, we were proven wrong. Here are 4 criteria by which we should judge the quality of the study question, and this applies to all research questions, not just the CAP trial study question. These criteria are uncertainty, clinical importance, scientific plausibility, and feasibility. Uncertainty means simply that the study question has not previously been answered. In the case of a treatment trial, there should be sufficient doubt about the risks and benefits of the test intervention. But I should stress that uncertainty is not another term for ignorance. We can reach a conclusion of uncertainty only after careful review of all the available evidence. In 1998, I was on a short sabbatical and in a relaxed mood. And one day I was browsing the website that in those days contained the neonatal Cochrane reviews. Of course, there were far fewer back then than are available to us today. Later that same day, I wrote to a good friend, Peter Davis, in Melbourne. I was absolutely horrified to see how few infants have ever been randomized to theophylline or caffeine, and that all we know is that these drugs reduce short-term apnea. I did not honestly know that the evidence was quite this flimsy. In the following year, I published this invited commentary in the Journal of Pediatrics, and the goal really of this article was to raise awareness of the limitations of the clinical evaluation and the available evidence on this class of drugs, the methylxanthines, which include, amongst caffeine, also aminophylline and theophylline. And the whole class really has the same types of actions. For the title, I borrowed the classification of sound practice, disaster, or fruitless byway from the late Bill Silverman. And those of you who have read his work, Dr. Silverman was a pioneer of evidence-based neonatology before that term had been invented. The next criterion by which to judge the quality of the study question is its clinical importance. And in the case of a randomized treatment trial, it is really not important only what we ourselves think about the importance. We tend to think it's important if we want to study it. No, we really need other people to believe that it's important, because in a trial like this, we need buy-in from our colleagues and the families of our patients in the case of our neonatal specialty. These people must want to find an answer to our study question because it makes a difference in their medical practice and in their lives. And it is a fact that commonly used practices will attract more interest than therapies that are rarely prescribed. So in 1998, which was the year in which we prepared the grant application for the CAP trial, I contacted Shu Lee, who was then the director of the Canadian Neonatal Network, to find out how commonly methylxanthines were actually used across Canada in the 2 preceding years in our target population. And here is his answer, and you can see that close to half of the infants received methylxanthine on day 3 of life. So this confirmed fairly frequent use despite the flimsy record of clinical evaluation at the time. Of course, today those numbers would be closer to 100%. Scientific plausibility is the next criterion by which to judge the study question. If we test in a treatment trial a novel therapy, of course we should have a biologic rationale for its hypothesized benefits, and I should add at least some preclinical evidence to its efficacy. If, however, we question the safety of an existing therapy, as we did in the CAP trial, we must be able to provide experimental evidence that suggests potential harm. So why were we concerned about the safety of routine use of caffeine and the other methoxanthines? Caffeine and aminophylline and theophylline are all non-specific inhibitors of adenosine receptors, at least at the standard drug doses that we tested in the CAP trial. Adenosine is produced in all our tissues, including the brain. And the adenosine levels rise in the brain when energy demand outstrips supply and brain cells are at risk of dying. Such situations of an imbalance between ATP synthesis and ATP breakdown include hypoxia, ischemia, hypoglycemia, seizures. You recognize the conditions that, unfortunately, we encounter quite regularly in our very preterm patients. So adenosine protects the brain from permanent injury due to energy failure. And when we block these receptors with caffeine or other methoxanthines, we basically inhibit a natural protective mechanism. And certainly in multiple animal models, this has very unpleasant consequences. Feasibility is the final criterion by which to judge the study question. Many investigators underestimate the difficulties they will face in recruiting the patient sample, administering the study intervention, and following all study participants for the most important outcomes. It is, of course, easy to judge feasibility in hindsight. History has shown that the CAP trial was feasible. We enrolled the target sample size of 2,000 infants, and we assessed outcomes in 3 follow-up phases at 18 months, 5 years, and 11 years. Attrition was very low at 18 months and still acceptable at 11 years. Having discussed in some detail the aspects to consider when formulating and evaluating a question, in this case for a treatment trial, we move on to the network of collaborators. Our network was not a formal network, such as, for example, the Neonatal Research Network in the US. It was more of an ad hoc network of friends and friends of friends. In some ways, this actually had some advantages because each participating NICU made an individual and local choice to join this particular trial. This slide shows some, but not all of the CAP investigators because they would not all fit onto one trial. But the point here is that generating enthusiasm in many people and then keeping the momentum going for a good number of years is one of the biggest challenges once a trial is underway. It takes a fair amount of ingenuity and effort, but ultimately it's about building and then maintaining relationships. This painting by Edward Hicks is called Peaceful Kingdom, and it hangs in the National Gallery in Washington, D.C. Many years ago, my husband sent me a postcard reproduction of this painting with the following words scribbled on the back. This is your version of the truth. The lamb and the lion and the baby all lie down in peace and harmony together. And here's quite a different version of the truth, vividly expressed in this painting by Charles Rowley in the same gallery and entitled Law of the Wild. Relationships among collaborators may not be always entirely harmonious, but they certainly should never be savage. A few words about funding. In The Canadian Institutes of Health Research, short CIHR, we certainly had a supportive funding agency, and I will explain in the next 2 slides why I'm concluding this. Problems with patient recruitment or patient accrual are the single most common terminated early, both in adults and children. This particular study was published 5 years ago in Pediatrics, and the investigators here just examined pediatric randomized trials, 104 of them, that had been discontinued before the planned sample size had been enrolled. And you can see that of the reasons given as to why these trials basically failed, problems with patient accrual topped the list once again, so there are no surprises. In this collection of abandoned trials, patient accrual problems were amounted to more than 1/3. In this situation that I just showed you, funding agencies respond differently, and some are discontinuing or cutting off funding more readily than others. As I had indicated, CIHR was very supportive and patient, and I'll show you why. This is an early recruitment graph for the CAP trial. So this is from one of our many internal documents of those recruitment graphs, and it shows the dotted line across is the anticipated or expected recruitment, and the solid line, the actual recruitment. And this is about the first 15 months into the trial. And you can immediately see that our early enrollment was slow and woefully behind expectations and predictions. We responded to these depressing statistics by adding new study sites and by actually extending the enrollment period from 2 years, which we had optimistically projected, to 5 years. I must add, however, that we did not ask the funding agency for extra money, just extra time. And this, of course, is only possible if your budget is a budget per patient enrolled and followed, not a budget per study site, where the site receives a payment, a fixed payment, irrespective of performance. And I'm sure you can guess that I am a great fan of the per patient budget, because it gives you a lot more flexibility to cope with problems such as recruitment problems, and also to reward good performance. I cannot stress enough the importance of working with an experienced and proactive data coordinating center. A successful collaborative trial needs a lot more than a central database. Our study coordinators at McMaster University were in touch with the staff and investigators at the local sites frequently, and sometimes daily if necessary. They perused and reviewed incoming data, issued data clarification requests where necessary. Every month, study reports were prepared for recruitment, record completion, follow-up completion, sent out every month for many years with a monthly newsletter. The coordinators worked particularly hard with the local sites when it was becoming apparent that babies and children might slip out of follow-up windows, to try and see how one could go jointly the extra mile to salvage this particular assessment. Basically, we wanted to know at any one time what exactly was going on in the center with respect to our trials. And we actually had a motto at the neonatal trials group, and that was no news are bad news. Professor Robin Roberts, our senior statistician shown here on the right-hand side, was involved in our projects from the very first beginning, from the initial formulation and fine-tuning of the study question. We took the warning of the great Sir Fisher, he of the Fisher's exact test, very seriously. Sir Fisher is quoted as having said, "To call in the statistician after the experiment is done may be no more than asking him to perform a post-mortem examination. He may be able to say what the experiment died of." And then there is luck, because, as I said, things can happen outside of your control that may actually completely derail the trial. And I think in neonatology, for me anyway, the most memorable and sad example is DART, Dexamethasone in tiny babies, a randomized trial. Lex Doyle and his colleagues in Australia designed and launched this trial at the turn of the century, so about 20 years ago. And the next slide shows you the DART study question. Basically, they wanted to resolve the uncertainty that we collectively have about the risks and benefits of moderate doses of dexamethasone given to extremely preterm or extremely low birth weight infants who are stuck on the ventilator after the first week of life and therefore have evolving BPD. And the main outcome was death or disability at 2 years. But just as this trial was beginning to be underway, within a few months, a tidal wave of expert opinion swept through the neonatal community, condemning basically all use of postnatal steroids. I call it hysteria, what happened back then, but the consequences were devastating, because within a very few short months, enthusiasm for this trial was so severely dampened around the world, it was an international trial, that enrollment had to be abandoned after just 70 infants had been enrolled, when the target sample size was well over 800. And wouldn't it be nice in 2021 if we had the answer to this question? In my view, looking at the neonatal trials out there and those that have been unsuccessful, I think that we allowed this to happen is one of the greatest tragedies of neonatal research. A final few words about the principles of research ethics. Basically, the principles of research ethics are no different than the principles that should guide all of our interactions with our fellow human beings. They are respect for persons and their dignity, beneficence, and justice. In our trials that we conducted through the Neonatal Trials Group and later in the Neonatal Research Network, we have seen that if research is introduced to families with honesty, trust, and respect, and also conducted in this spirit, then most parents actually respond very positively to this type of research. And they may see their research participation more as an opportunity than a burden. But having said this, there is no question that some unethical investigators exist, including today. The French artist Honoré Daumier, quite some time ago, already knew that every profession has a few black sheep, and physicians are no exception. In this drawing by Honoré Daumier, you see this feeble elderly lady in the armchair in the background, and in front, those are two physicians who are having the following conversation. "Oh no," one of the physicians says, "the patient is weak. She wouldn't survive. The operation is impracticable." The other answers, "Impracticable? Nothing is impracticable for a beginner. Listen, we have no name yet among the profession. If we fail, we don't lose anything. If by chance we succeed, we'll be launched. Our reputation will be made. And both, let's go ahead then." I thank you for listening, and I look forward to our discussion later on.